All right, well, we're going to get started here. Welcome, everybody. So this is the Illuminating series. My name's Holly, and I work with Lumina Hospice and Palliative Care. And we also have Nathan with Care Partners as co-host today, helping me out. So just some quick background on the Illuminating series. It's a monthly seminar that takes place every third Tuesday. And we have experts on various topics that relate to end of life in one way or another. And so for those who have joined us in the past, this may look a little bit different as we have folks from other areas joining us. And this is a collaboration of the Oregon Nonprofit Hospice Alliance, which consists of 3 hospice affiliates, including Lumina and Care Partners. So we hope you enjoy what we've got going on here. Today, we're going to be hearing all about end-of-life choices. And if you do have questions throughout the presentation, feel free to put those in the chat box. And we'll be keeping an eye on that, and we'll just kind of answer things as they come up. And also keep in mind that we are recording today's presentation, and so we'll be able to send that to you afterwards. In the next couple of days or so, we'll email that to you. And a little bit of background about our presenter before we get started. So we have Sue Porter today, founding director and co-board chair of End of Life Choices Oregon. She's been working in the field of medical aid in dying for over 2 decades. She has a master's of science in bioethics and a master's in business administration. She also completed a diploma at Yale's Interdisciplinary Center for Bioethics and was a visiting scholar in residence at the Hastings Center for Health, Science, and Technology Ethics in New York. Sue has also served as director on both the national and Oregon boards for Compassion and Choices. And for 23 years, Sue has worked directly with terminally ill people availing themselves to Oregon's Death with Dignity Act. And she's spoken nationally on the right to die and was a participant in How to Die in Oregon, which is a documentary that won the Sundance Film Festival. Okay, so now I'm going to bring Sue on the screen for you. All right, take it away.
Okay, well, first of all, I would like to thank you for this opportunity to speak to your organization. I thought, and it doesn't matter to me in the least, but I thought this was for Care Partners, but you mentioned another, or the ONHA, so pardon my title slide because it says Care Partners on it, but everyone counts and it doesn't matter to me. So thank you for this opportunity. If you have any questions, Holly will field them as we go along, because I would much rather hear your questions as I present instead of at the end. And I have one question. We have up here a Patricia Moore and a Jane Foreman. We have both of those names in our organizations. It is Patricia Moore. And Jane, is that you? Oh, it's Ani Sinclair. Okay, I'm a little confused, but I will start. Okay, I'd like to start with our terminology, what we use, and this applies nationally, not just in Oregon. Death with Dignity is the name of Oregon's law. Each law has a different name. Each state has a different name for their law. Generically, this is called medical aid in dying, or we refer to it as MAID. And we really avoid the term assisted suicide. In medical aid in dying, you'll see that the people, unfortunately, do not have a choice. They're going to be dying anyway. It is not a problem that can be solved. In assisted suicide, a lot of people commit suicide due to problems that may have a solution. It is not prepared. People are left in, family and friends are left in a horrible quandary. It can be physical, it can be bloody, it can involve what do I want to say, a police, etc. And the mourning period is totally different. So we really do not refer to medical aid in dying as any type of suicide. When we meet with people at end of life choices, we make sure that they are informed of all of their choices. Hospice and palliative care, refusal or withdrawal of medical treatment, which most people, when they come to us, are already on hospice, so they've already refused further curative care. Voluntarily stop eating and drinking, and Oregon's Death with Dignity Act. We make sure that the person who is availing themselves to medical aid in dying is the person making the decision. Many of our calls come in from caretakers. It could be a daughter, it could be a neighbor, it could be a good friend, etc. And we definitely accept those calls because we realize that the person who is dying may not be able to make the call themselves. Many times they are on medication, they're hard of hearing. It's just too difficult for them to talk on the phone. So we do take the intakes from other people, but when we meet with the person, we make certain that the request is coming from them. Most requests come to us due to existential pain, not physical pain. It's the burden of existential pain, such as, I saw my cousin go through this. I don't want to go through it any further. I know what the future will bring. I have been disconnected from so many people as I got sick. The three most prevalent reasons that people give for pursuing medical aid in dying is a lack of control, lack of dignity, and inability to pursue life's pleasures anymore. If they have physical pain, we refer them back to their hospice or to their doctor if they're not on hospice. I want to make clear that End of Life Choices Oregon is not a medical organization, and we draw a very bright yellow line about that. The death with dignity requirements are that the person has to be terminally ill as prognosticated by 2 doctors, and I will go over the responsibilities of those doctors. But if someone today is told that they have pancreatic cancer, they are not, their disease is fatal, but it's not terminal. They could live another maybe year or 2 with pancreatic cancer. So it has to reach that 6-month mark. Has to be an autonomous request, no coercion, like I explained before. They have to have decision-making capacity. Sometimes people say mental capacity. Well, what does that mean? It has to be decision-making capacity. We do not ask people to recite the capitals of the US, but they have to have decision-making capacity. Physical capacity in that they have to have the ability to self-administer the medication. That means for the most part, they have to swallow about 3 to 4 ounces of a final prescription. At this point, there are, it is allowed that if the person can't swallow, they can have this administered rectally. However, they have to push the final plunger or push the button that will administer the medication that goes into their body. Same thing with a feeding tube. If anybody else does this for them, it's euthanasia. It's someone making someone else die. And I want to be very clear that this is illegal, not only in Oregon, but throughout the whole United States. And they have to be a minimum of 18 years of age. Non-qualifiers, and this is really important because there's a lot of misinformation about this. A fatal disease of more than 6-month prognosis, like I just explained regarding pancreatic cancer. A chronic degenerative or debilitative disease that goes on and on. If it's not terminal, they don't qualify. Trauma-related disabilities or isolation. If someone is in a fire or car accident or in battle and they lose a few limbs and they lose their eyesight, for example, they do not qualify because they are not terminal. And isolated people, once in a while, we get a call from someone who is 92 years old or 89 years old, and they say, my family lives back east. I don't have any friends anymore. I'm not hungry. I don't enjoy my food. I can't watch TV. I can't read, and my life is over for me. They do not qualify. Again, terminal disease. Dementia does not qualify either, and that is a very controversial subject, but the person has to have decision-making capacity at the time they go through the legal process of availing themselves to death with dignity, and at the time that they're going to take the final prescription to die. And I say that because many times people have gone through the process, but they decide that they don't want to take that final prescription at that point. They might be waiting for to see their granddaughter's wedding pictures, or sometimes they say, my husband and I are going to have our 55th wedding anniversary in 6 weeks, and I want to be alive for that. There are different reasons that people put this off, and a lot of them have availed themselves just so that they have control. But if they wait and sometimes have a stroke in between or lose decision-making capacity, they don't qualify anymore. So we always want to make sure that people know that. The legal process, I'm going to give you the legal process in very simple terms. The way the law is written, it's very, it looks very linear. You go from A to B to C to D. Work knows that there is always what I call a hanging chad. So this is a overview of the law, but we always have to go through some other hoops due to various reasons. There are 2 oral requests separated by a minimum of 15 days. So for example, if someone gives their first oral request to a doctor on October 1st, the process has to be a minimum of 15 days. The exception to that is the next sentence. If the prescribing doctor thinks that the person will die in less than 15 days, she or he can expedite that process. And I want you to know how important that amendment was to the law. It was passed in 2019. In 2020, there were 20% people who were expedited. In 2021, there were another 20%, and in 2022, it was 25%. So people don't know that they need to come to us. I mean, how would they know? They haven't looked at the law prior to when they need it. but an exception can be made by the prescribing doctor. After the person has given their first request, let's say on October 1st, to the doctor, to one of the two doctors, he or she only has a few things that needs to get done. One of them is to sign the request for medication. And this is a very simple form. And I want you all to know that we walk shoulder to shoulder with you through this, through any hospice person, with the family, etc. So you don't have to memorize all this. But the request for medication is a very simple one-page form. And what that person signs is that they are aware of their disease, they are aware of their options, they've been told what the different choices are, etc. And it requires 2 witnesses. It does not need to be notarized, but that must go to the prescribing doctor before he or she writes the prescription. So that's one thing that needs to be done after the first oral request. And the other thing is to see the consulting doctor. 2 doctors need to agree on the prognosis. I will say in my all my years, and I'm starting my 24th year of this, I've never seen 2 doctors disagree. However, I have seen the first doctor say this person doesn't qualify. So they've given their first request. They have signed the request for medication with 2 witnesses. They've seen the consulting doctor, and then they have to give their last request on the 15th day or any day thereafter. I like to describe this as an open face sandwich. It's not closed. It does not mean that after the 15th day, if they have not given their second oral request to the prescribing doctor, that everything is gone. They can give that request on the 16th day, the 23rd day. It doesn't matter. It just cannot be done earlier than the 15th day. After that, the doctor can write the prescription. I also want to say that in Oregon, these meetings with the doctors and the requests can be done by telemedicine. So the physician can write the request after he or she has received the request for medication and the person has gone through all these steps, and the physician needs to either physically deliver the script to the pharmacy or they can mail it. And sometimes doctors use courier services. The script does not go to the patient or the patient's family. I'm using the word patient. We at End of Life Choices Oregon, again, I say we are not medical people, and we call them clients. But for your benefit, I'm referring to them as patients because I think you're medical people. Are there any questions so far?
I haven't seen any come in the chat yet.
Okay. The physician's responsibilities. There are 2 Oregon licensed physicians. They can be MDs or ODs. There's a prescribing and there's a consulting physician. They must see and approve the patient for death with dignity. And again, it can be done by telemedicine. They have to agree on the terminal prognosis and the mental and physical capacity. And they go over forms that are required by the state, in which they ask very specific questions of this patient, and there is a form of informed consent, making sure that the patient understands what it is they are availing themselves to. There's something in the chat, Holly. Do you want to?
Yeah, it says, how receptive are physicians in Oregon to this law?
Oh, that's a very good question. I will go over those statistics at the end. I will answer it by saying right now, they are much more receptive than they used to be. There's also some medical centers that will not allow them. It's public information. One of them is Providence, will not allow their physicians to be involved. There might be others throughout the state that I'm not familiar with because I'm in Portland. But I'll go over those statistics in just a few minutes.
Okay, we had another question. Can both doctors be part of the same practice?
Yes. But one doctor can't tell the other doctor to just look at the electronic files. They both have to meet with the patient. These are the medications, Halidol or Zofran and Reglan. The person takes these 3 small pills about an hour before they take the final medication. And that is to relax them, and it's for better digestion. Here is the prescription. It's a compound prescription. All of this is mixed together in powder. Last week, I was asked if each one of these is taken separately. The answer is no. They are all mixed together in powder form, and then the person can choose what they want as liquid. It can be, most people either use water or apple juice for some reason, but it can be anything that is not dairy lined and is not carbonated. We mix this with 2 to 4 ounces of whatever it is they choose. They can even do it with liquor if it's a clear liquid. They then swallow this. Oh, excuse me. I'm sorry. We mix it. And when I say we, the family and the patient always has the choice to have us there. I'm going to say 95% of the time we are there, and we show up in twos. We always like hospice to be there, although there's nothing that requires them to be there. There's nothing that requires us to be there. There's nothing that requires a doctor to be there. But for the most part, we are there, and we mix this powder form with whatever liquid they choose. They go then, when they drink it, and we ask that they drink it in about 90 seconds, and they don't have to chug it. Some people start chugging it, but we don't want them to chug it. We want them to finish it. We want them to drink it before they go into a deep sleep. It tastes very bitter, no matter what it is mixed with. I also want to say that before we prepare the prescription, we ask them the following questions. We ask them if they would like to change their minds, and I personally make sure that there are other people around the bedside to make certain that everyone knows end-of-life choices is not forcing this on anyone, that is up to the patient themselves to make this decision. So the questions that are asked of them is, would you like to change your mind? And in my experience, I've had 2 people who did change their mind at the last minute. The next question is, what is this prescription going to do? And sometimes people answer humorously, like, I'm going to a big golf course in the sky, or something to that effect. And we just keep asking, what does that mean? What does that mean? Until it's clear that they are communicating to everyone around the bedside that they know that they're going to die. And the last question is, whose decision is this? And when they say it's my decision, we say, did you get any pressure to do this? And the answer is no. But I've never been in a situation where the answer is yes. Maybe some of my colleagues have, just so that you know, there are about 70 or 80 volunteers throughout our state who are doing this. Holly, I see two in the chat. Are those new?
No, those are the same two.
Okay. Working with hospice. The Death with Dignity hospice enrollment the last few years have varied from 91% to 98%. If someone is not on hospice, we highly encourage them to get on hospice. The two most prevalent points of resistance are that they think it's going to cost them, and we assuage that. We tell them that it's not going to cost them. And the other point of resistance is, I don't want someone just coming into my house anytime. And we tell them that hospice makes a plan according to your specific needs. They make appointments. You have the choice of a chaplain, there'll be a social worker, and there are volunteers who also help the caretaker. And from that, I think for the most part, people do sign up for hospice. Of course, we respond to hospice referrals. And we work, I like to say, as an adjunct to support hospices. Hospice has a national credo in which they do not hasten, nor do they slow down death. And so there's a bright line in which we do that work for them. And the bright yellow line also means we don't do any medical work. So we work as an adjunct with hospices who need our help. And of course, the patients, their patients and their families. Supporting the family at the time of death. The process is explained in detail to the patient and the family, and that they will take the pre-meds. About an hour later, they will take the final prescription to die, and how and what will happen then. They will go into a deep sleep within about, it varies, I'm going to say 3 to 7 minutes. And from that point on, the person will not know what is happening. We get asked repeatedly about how long it takes for the person to die. The pat answer to that is minutes to hours. We can never tell. And it's very important not to put a timeline on it, because for example, if we were to say, and I'm making this up, if we were to say most people die within 3 hours, our experience in the past has been, if it takes longer than 3 hours, at 3 hours at 5 minutes, 3 hours or 10 minutes, the family and the friends start getting very anxious. Oh, what happens next? Is mom going to wake up? Are you sure that the medication was correct? Has this happened before, etc.? So in order to avoid that anxiousness, we say minutes to hours, we can never tell. Sometimes it's minutes, and we have also had some that are extended that we cannot answer why, like over 24 hours, maybe 30 hours. I don't know the statistics of that. It's very, 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 very rare, but it does happen. So, I already went over the 3 questions we asked the people before preparing the medication. The patient digests the pre-meds, and then the patient ingests and dies peacefully. There have been some very rare random situations in which the person woke up. I don't know exactly that number, Maybe Patricia or Jane know the number. I'm going to make it up. I'm going to say maybe 6, 8, or 10. I don't think it's been 10, but I really don't know. And that's been over, we're on our 26th year of doing this. And it would apply to the state. It would not apply to just Portland. Here's some relevant information. So to answer the question, in 2002, there were 24 physicians who prescribed. In 2022, in Oregon, there were 133 physicians, and some of them did multiple prescriptions. Because as you can see, the number of prescriptions written were 431 in 2022 by 133 physicians. The deaths were 278. 278 people took the prescription to die. And every year, in last recent years, it is that same statistics, that 65% of the people took it. However, what I want to say is, I'll go over, I think it's the next slide, what that remaining 35% consists of, because these statistics are taken at the end of the year and some people are still alive, but I'll go over that in a minute. In 2022, the median age was 75. It's usually between 71 and 75. And hospice enrollment for some reason was a bit down. It was 91%. I think I mentioned this, the primary reasons for using medical aid in dying in Oregon was existential, inability to pursue life pleasures, loss of control, and loss of dignity. If they are telling us that they are in pain, we refer them back to hospice or back to their doctor.
So we had a question. Who determines legal death during this time?
We can do that. If there is not hospice, if there is not a doctor, we can do that. And sometimes a hospice person will show up afterwards. For the most part, I'm going to say hospice is there, but not always. But we can do that. From 1998 to 2022, these are the statistics. And again, you'll see about 35% of the people, these people could still be alive, not the ones who did this in 1998, but from the end of the year, still alive, or they died from their disease, they lost eligibility, or the state knows that they died, but they don't know how they died. And I want to give an example of someone who lost eligibility. It was a lady who had a glioblastoma, and she called one day to say that her whole family was there and she wanted to take the prescription to die the next day. And I went there with one of my colleagues, and she had completely lost decision-making capacity or the ability to communicate overnight. So when I say lost eligibility, this is what can happen. It doesn't happen often, but we had to recuse ourselves. I also want to say that in communicating, it does not need to be orally. We work with people with motor neuron diseases, and for example, ALS, and they have different ways of communicating, and any of it that is clear works fine. Common concerns. So what types of physicians can be involved? I think I already said this, but it's a Oregon license, MD or DO. Does insurance company pay for the medication? Very, very, very rarely. Most of the time, these people are on Medicare. Medicare does not cover it. And if they're not on Medicare, we don't work with insurance companies. We have them call their insurance company, explain it. Once in a while, an insurance company will pay for it, but it's rare. And does life insurance policy compensate? The answer is yes, because on the death certificate, it says that the person died from their disease. This is in the law. It does not say that they died due to death with dignity. And if the state receives from a doctor that the person died from death with dignity, they send it back to the doctor to correct it. So those are some common concerns. In the United States, these are the jurisdictions that have a medical aid in dying law. I use the term death with dignity, medical aid in dying to you, but all these states have different names for their laws. The most liberal one is New Mexico. They have a 48-hour waiting period, and they only require one doctor if the person is on hospice. The hospice doctor counts as the second doctor. California just changed from 15 days to 48 hours. And there's a few of them who have done this. Hawaii used to be the most conservative. They had a 20-day waiting period, but they recently changed it to 7 days. I also want to say, I forgot to mention earlier, that if either of the two doctors think that the person needs a psych evaluation, then it is required in Oregon. In my years, I have only had that happen twice. So it is very rare, but we do abide by it if one of the doctors thinks that's necessary. This is our contact information. If anyone has questions, please feel free to contact us. Again, I want to emphasize that this is an overview, that whatever patients or clients you are working with, we are shoulder to shoulder every step of the way. And we are more than glad to work with you. There are there's a few more questions, Holly. I see 5.
Yeah, one came in. Do any other states cover non-qualifying conditions?
No, all the states require a 6-month prognosis, terminal illness.
Okay, if you have any questions, feel free to put them in the chat. Could you tell us a little bit more about, you mentioned volunteers, and like just a little bit more about what those people do for your organization?
Yeah, our organization is made up of 5 teams geographically: Portland, Salem, Eugene, Bend, and Southern Oregon. And we have about 70 volunteers. And what we do is when someone calls, and an intake is done, and then it is assigned to the appropriate geographical region, and then a team leader assigns a volunteer. The volunteer contacts that person or their family, sets up an appointment, meets with them, and explains the whole process. They are with them again, shoulder to shoulder through the process. They meet with them repeatedly, or if they would prefer phone calls, they do whatever that family or that client wants. I always say to the client, you are my boss. You tell me what you want, and as long as for our help, and as long as it's legal, I will do it. So we're with them throughout the whole process. Sometimes, actually, oftentimes they don't have two doctors who will avail themselves to this. So we try and find some doctors. We actually have some pro bono doctors on each team. But anyway, we try and find them doctors. We can never promise them 100% that we can, but we usually can. And then the doctors make appointments to see the people either personally or by telemedicine. We, when the whole process is finished, we are there if and when they decide to take the final prescription to die, if they want us there. Again, I'm going to say 98% of the people want us there. We explain the law, we explain the process repeatedly because there are different members of the family who weren't there at the last meeting. We answer all their calls as they come in. Does that answer your question? And we work very closely with hospice.
Yes, thank you.
Okay.
Another question, how much do the drugs typically cost out of pocket? And assuming that it's a lot, is there any assistance for things like that?
Okay, it costs about $650. And there is an organization in Washington, the state of Washington, called the Costigan Foundation that will help depending on how much funds they have available. If there is a situation in which someone does not have that $650, we ask them to ask family or friends, anyone that they can, and whatever is needed, we will appeal to the Costigan Foundation.
Okay, let's see. Have you experienced any significant resistance from family members?
Good question. If there is resistance, first of all, I'm going to say, and maybe Jane Foreman can answer, maybe she's had a different experience, I'm not sure, or other people. My experience has been that there are very few families that do resist. Sometimes there's someone who says, I don't believe in what dad is doing, but I will support him. If there is a situation in which they want us to talk, our policy is we do not get involved in the family soup. I had one lady who wanted me to talk to her doctor, her daughter, years ago. And she said that her daughter wanted to phone me. And I was very clear and said, I am not going to be talking her into supporting this. I will answer her questions about the law, but we don't get involved in trying to talk anyone into this.
Okay. Let's see. Oh, Jane just commented that OHP or Medicaid will often cover 100% of the cost of the medication.
Yeah, thank you, Jane. I forgot to say that.
Is there any interest in Oregon to expand death with dignity to include some current non-qualifying conditions? It seems to now only cover cancer and heart-related diseases.
Well, first of all, there's nothing going on in Oregon for that. But besides cancer and heart-related, we also work a lot with neurodegenerative diseases and also pulmonary, COPD.
Okay, any other last minute questions? I think we've covered everything that's in the chat box.
Okay, I would just like to give the opportunity to Jane, if you think there's anything that I'm glad you added that last comment. Is there anything you'd like to add on, or Ani or Patricia, that you think that I have overlooked?
I will just add that in terms of qualifying conditions, it is a really mixed bag. It's not just those two, cancer and heart related. For example, I've got a client now who has a very bad infection. She's been given a 6-month prognosis. Some of these neurodegenerative diseases, I hate to use the word doctor shopping, but that is kind of what we advise clients. If you have ALS or Huntington's chorea, something like that, and your neurologist will not give you a 6-month prognosis, maybe another one will. So there certainly are these neurological conditions where they can get a 6-month prognosis. It's just really all over the map. I mean, I've seen old age given as the 6-month prognosis. So it really is kind of all over the map. It's not just limited to those two categories.
I would also like to add to that what Jane is saying is if the person is on hospice and one of our and hospice will provide a CTI, which is a certificate of terminal illness, one of our pro bono doctors will work with them so that the person does not have to work real hard to get their own doctor. Ani, do you have any comments?
Ani put something in the chat. Would you mention our working with hospices for a person who wants to use VSED even in cases of dementia?
You know what, Ani, I'm going to have you address that because that hasn't come up with me personally, and I don't want to give wrong information.
All right, I'm happy to discuss it. We just recently had a statewide training about voluntary stopping eating and drinking. And it is becoming more known that this is a possibility to prevent a person having to live long time with dementia. And we work with hospices, and we're so happy. Usually the client would enroll with the palliative care portion of hospice in the beginning and discuss the plans. It takes a lot of planning and support for a person to use this method for peaceful death. And so once they have everything in order, and our volunteers are also taught all the things that they need to know in order to support someone through this process. And then after the 3rd or 4th day, the client would usually qualify for full service hospice due to organ failure at that time. And then hospice heroically comes in with the support that hospice provides for the final days of that. And usually VSED takes, again, you can't predict it like Sue was saying, but it's usually be around 2 to 3 weeks, and they need to have 24-hour care for that time. Thank you so much.
Thank you, Ani. I appreciate that.
Okay, we had another question. I can take this unless you want to, Sue. It's what's the difference between hospice and palliative care?
I think I'll have you do that.
Okay. So the short of it is that hospice care is for people who have a terminal diagnosis or they're not seeking treatment anymore and they have about 6 months or less to live. And the goals for palliative and hospice care are very similar. It's, providing comfort, relieving folks of symptoms and pain. It's really about quality of life. And palliative care is just a little bit different in that folks can have a diagnosis of 1 year to live, up to 2 years in some cases, and they can still be seeking curative treatment under palliative care. So those are kind of the short answers to that question.
I think that there's a misconception with people that palliative care only happens at the end of life, but it can happen anytime.
Mm-hmm. And palliative care at home. Yes, so hospice and palliative care both can happen in your home if that's what you want. Our hospice here at Lumina, we do not have a facility. We don't have a hospice house where we're providing care. And in fact, none of these affiliates with ONA do. There's only 4, maybe 5 now hospice houses in the entire state of Oregon. So that's really a place where folks go when they're at their highest need of they have a high level of care that's needed. And the goal really is to kind of get that under control, and then the goal is for them to go back home. So that's kind of another common misconception we see is, you know, hospice house is not where people get sent to die in their final days. But yes, we provide care wherever someone calls home. So it could be their patient's home, a family member's home, a skilled nursing facility, assisted living facility, really anywhere we can provide care.
Okay. I think another question came in.
No, I'm just seeing the ones we already did. So I don't think we've missed any questions yet.
All right, Patricia, do you have anything you would like to add? Patricia Moore?
No, I agree with what's already been said, and it actually struck me from what Ani mentioned that there might be interest in the future to have one of these sessions on VSED. The thing I'd add to what was said about OHP covering the medication, they will cover it as long as the client has the drug provision of Medicaid.
Thank you for that clarification.
And by the way, great presentation, Sue.
Thank you. Ani, if you're going to do this on VSED, I want to know because I want to watch VSED and dementia. Okay, thank you so much, Holly. Thank you all for attending. Holly, could I ask you something real quickly? How many attendees were there? So I don't have to bother you afterwards. About, do you know?
Oh, sure. Looks like we ended up with 25 on the call today.
Okay. And then they will have the recording if the others will have the recording. If, okay.
Yeah.
Thank you for attending. All of you have in front of you the screen of how to contact us. We will be glad to respond to you with any questions at any time. And of course, if you're working with terminally ill people, where our services are available to you. And Holly, thank you for this opportunity. I'm sorry that I thought it was Care Partners. I talked to someone from Care Partners yesterday, and but thank you everyone for joining.
Thanks so much, Sue, and thanks everyone for joining us. Like I said, you'll get an email in the coming days with the recording and probably a link to End of Life Choices Oregon website. And we hope to share with you also information about our next Illuminating series next month. So thank you all for being here today.
Thank you.